Modern high tibial osteotomy for medial compartment osteoarthritis of the knee by Dr. Milind Chaudhary. Let us begin, as usual, with the great Robert Jones from Liverpool in the late 1850s, who was first known to perform an osteotomy in the middle level of the tibia or shin bone in Liverpool. He is rightfully considered the father of modern orthopedic surgery. In the English-speaking world, Jackson and Waugh from Nottingham, England, were supposed to be the first to describe high tibial osteotomy, of which they described not just 3 but 6 different operations with different shapes: curvilinear above, curvilinear below, closing wedge, through the tuberosity, above the tuberosity, etc. Arguably, the most famous surgeon was Mark Coventry from Mayo Clinic, Minnesota, USA. In the early 1960s, he developed the closing wedge high tibial osteotomy and has become very famous for it because it bears its name. However, Dr. Mark Coventry was also involved in the development of total knee replacement, and he jumped ship and stopped the development of closing wedge high tibial osteotomy. We now come to my personal hero and the person who put closing wedge high tibial osteotomy on a proper scientific foundation and pedestal, Professor Tomohisa Koshino from Yokohama City, Japan. This is a photograph of him taken during a conference in Mumbai in 2010 April. Professor Koshino developed at least 2 varieties of special devices like a barrel plate and an angled blade plate, which helped to give very stable fixation to the closing wedge osteotomies. This allowed the osteotomy to be fixed stably, allowed the patient to walk immediately after surgery, and ensured that the correction was not lost. All of these were an improvement over Dr. Mark Coventry's closing wedge osteotomy. So in reality, he really refined the high tibial osteotomy technique. Most importantly, the entire world believed, after the onset of total knee replacement, that cartilage cannot regenerate. Perhaps, as a patient who suffers from knee osteoarthritis, you have also been told by your doctor that your cartilage is completely worn out and nothing can improve it, and hence you need to change your joint and put in a new artificial knee joint. I can tell you nothing can be further from the truth, because in the photographs that you can see on the left hand side is a patient who has completely lost the articular cartilage in the side of the femur, and on the right hand side, 1.5 years after the surgery, you can see glistening white smooth cartilage has covered the end of the bone because after high tibial osteotomy, the excessive load on that part of the joint was removed, and it gave the chance to the joint to breathe and to regrow cartilage. This was the most fundamental discovery of Professor Coscino. On May 18, 2016, Professor Coscino fell prey to advanced stomach cancer and passed away, leaving many of us grieving and hoping that may his soul rest in peace. On the other side, on the European continent, Debayer and Artigue in 1951 first reported on a medial opening wedge high tibial osteotomy in Paris. Debayer was followed as the head by Philippe Arnigoux, who has continued to perform more than 4,000 such operations over the last 40 years. Arnigoux recognized the importance of the posterior tibial slope and many other technical niceties of the medial opening wedge high tibial osteotomy. With the advent of the Autofix external fixator, this group in northern Italy discovered a way of gradually distracting apart a medial opening wedge high tibial osteotomy using the fixator and allowing triangular shaped bone to form and hence correcting the deformity in the upper tibia. This technique they called hemicalotesi and has become very popular wherever external fixation is used. This method has also been used in India and is extremely popular the world over. Today, however, the state of the art is considered the opening wedge high tibial osteotomy when it is combined with rigid plate fixation. On the left you see Professor Philipp Lobenhofer of Hanover, Germany, and on the right you see Professor Alex Stobli of Lucerne, Switzerland. Alex Stobli is widely regarded as the father of the Tomofix plate. He invented it. It's a special device made from titanium alloy, rather special alloy, which gives it tremendous elasticity and great strength. This operation makes it extremely easy for the patients to walk immediately after surgery, sometimes full weight bearing within a few days. Today, this represents state of the art of the high tibial osteotomy, and the results achieved by Professor Stobli remain the ones to be emulated. I have shared the dais with him as a faculty in many conferences, and I have learnt the technique from the great master himself. These diagrams show the biplanar high tibial osteotomy being performed by an oscillating saw and the Tomofix plate being applied and giving the pretension. The deformity is corrected by opening a wedge or separating the bone ends apart. There is no need to add bone grafts or bone graft substitutes, which can be rather expensive, to fill up this gap. That is because of the elastic nature of the plate and ability of the patient to walk. There is elastic micromotion and bone slowly fills in the gap on its own. On the other hand, the supratuberosity dome osteotomy was also developed in Europe by Paul Mackay and became very popular all over the world in the late 1960s and 70s. Many authors could successfully replicate his surgical technique, which was reasonably simple. It was an arcuate-shaped dome osteotomy performed above the tuberosity, that is, very close to the joint. Since the bones at this level are soft and broad, this osteotomy joins really fast and in many circumstances may be fixed only with a simple plaster cast. This has made this type of osteotomy extremely popular in the decades past. Revival of the high tibial osteotomy in the West came from the work of Eleazar of Technique. The Eleazar of Fixator spread and allowed accurate deformity correction in the upper end of the tibia, which is one of the hallmarks of any high tibial osteotomy procedure. Also, credit must be given to the sports medicine group in Cincinnati, led by Frank Noyes, who elucidated the role of high tibial osteotomy in sportsmen who damaged their ligaments and went on to develop a varus or a bowing deformity with their ligament laxity. The focal dome osteotomy, when fixed with the Eleazar of device, was designed by Dror Paley, one of the doyens of the Eleazar of Technique outside Russia. He was in fact the first student of Maurizio Catani, whom you can see on the right, who happened to be one of the earliest practitioners of the technique outside of Russia. Dror was my guru. I was his first international fellow and an eternal favorite for his tremendous inventiveness. This is a photograph of Dror taken in the year 2002 at the inauguration of his new center in Baltimore, USA. Finally, I would like to end this journey of the development of high tibial osteotomy by highlighting the work of a genius from Japan, Professor Tsukasa Terremoto, who comes from Koriyama City. He developed the tibial condylar valgus osteotomy. This is a very interesting osteotomy because it believes that deformity in the upper end of the tibia, that is close to the knee joint, does not just arise below the joint but also arises from within the joint. These series of diagrams go on to explain the osteotomy designed by Professor Terremoto. On the left you can see an extremely bowed lower extremity with the weight-bearing line from the center of the hip to the center of the ankle passing way inside the knee. Upon seeing in great detail, you can see that only one part of the tibia is articulating with the femur in the knee joint, and the joint teeters on the inside and on the outside as only alternate condyles make contact. In the next series of pictures, you can see that first an intra-articular osteotomy is made as a L-shaped cut. This elevates the condyle and allows both the condyles to simultaneously get into contact with the femoral articulating surfaces. This dramatically increases the surface area for loading in the knee joint and decreases the pressure on both the condyles, therefore reducing the pain and allowing the cartilage to regenerate. What's more interesting is that an extra-articular or an additional deformity below the joint can also be corrected with a dome-shaped or an arcuate osteotomy and fixed with an Eleazar of Fixator. On the extreme right, you can see that the deformity is now completely corrected at both the levels within the joint as well as just below it. This ingenious operation allows us to correct extremely large deformities in older patients who would otherwise have been condemned by most surgeons to undergo only a total knee replacement. Thus, as you can see, high tibial osteotomy is not an old and simplistic and forgotten operation. It is a wonderful surgical technique with many different facets and dimensions, and it is under constant evolution. It represents the biological method of treating osteoarthritis of the knee. If you want to preserve your knee, the surgery you need is a high tibial osteotomy. I thank you very much for your attention.